Hello again. The next talk will be on subliminal laser therapy for macular diseases. And to follow on from what Dr. Victor Chong has discussed in his overview talk on the history and many modalities of subliminal laser therapy, I'll be focusing on diabetic macular edema and central serous choroidal retinopathy. These are my financial disclosures. I've been working on the Quantel laser systems for the last 11.5 years, starting with the SuperScan, 532 and 577 nanometer lasers. And I recently upgraded 2 years ago to the EasyRed 577 nanometer laser system with the subliminal laser modality. So how does subliminal laser treatment work? Basically, it's very old technology that's been pioneered for more than 20 years. And what we need to know is that a proper subliminal laser is a train of laser pulses that are broken up in time. So we must understand a concept called duty cycle, which is the duration of on time and on and off time the laser has reached the retinal surface. And this is equivalent to a percentage. And what we're using in most cases is a 5% duty cycle, so a very low duty cycle to generate laser at the retinal pigment epithelium. The classical laser photocoagulation that you see is 100% duty cycle, whereby the laser is applied for the full duration of that you have set it for, and it creates heat at the retinal pigment epithelium and a dense laser scar. And this is what we want to avoid with subliminal laser technology. So by adjusting the on and off setting for subliminal laser, we managed to reduce heat diffusion around the surrounding tissue, and this prevents the formation of laser scars. The benefits are such that you can preserve retinal tissues while having effect on reducing macular edema at the macular area. The limitations is that many doctors complain that they cannot see these subliminal laser scars, and there's still some debate about what are the exact and best treatment settings we should use. In addition, I use the subliminal laser with the 577 nanometer wavelength, which I believe is the ideal wavelength to create a good laser reaction at the retinal pigment epithelium without damaging the zentrophil pigment, which is found predominantly at the macular region. Additionally, there's good penetration through opacities like cataracts, and you can allow you to titrate the power quite efficiently. We use a dense treatment or large spot size for the subliminal laser treatment, and the spot size is 160 micrometers, which are all connected together, which ensures a dense delivery of the laser scars, of the laser burns onto the retina without causing any scarring. Previous modalities or guidelines use small spot size with less laser burns, so there was a lot of gaps in between. This was done by small spot size and more laser burns with less gaps, and we then have moved on to a larger spot size with less laser spots, but maintaining the same density of the treated area. So these are the treatment guidelines that I would recommend: a spot size of 160 micrometers, 5% duty cycle, 0.2 seconds exposure time, using a Volt area centralis lens with a magnification factor of 0.94. This is all preset into the machine. So it's very important before you start treating is to titrate the power of the subliminal laser, because every patient is different. Some patients need a higher power, some patients need a lower power. So this is the only variable you need to make for subliminal laser. So once you determine the power level, whereby you choose an area outside the macular region, you use 5% duty cycle. I normally start at about 600 milliwatts. And if I see a mild reaction, I then reduce the power by half. And that is the treatment power that I need to treat the thickened areas around the macular region. So there is a power titration setting in the subliminal mode that you can follow. And it's very important that you do this. You don't exceed 1.2 watts of power. If there's no visible threshold happening at 1.2 watts, keep this as a reference level and use half of it for treatment. So 600 milliwatts, but I rarely have to reach this level. For the vast majority of patients, when you go titrate at 600 milliwatts, you see a mild reaction at 5% duty cycle. You reduce the power by half to 300 milliwatts, and this is what you need to do a good subliminal laser. So when you switch on the Easy Red system, you just have to pick the subliminal laser mode. And this comes up immediately under the titration power settings. And then you can start at 600. You can choose different levels of power and choose an area outside the macular region just to test it. And if you get a reaction, just click this button to reduce the power by half. Since the laser spots are not visible, you can use the multi-spot delivery system to ensure homogeneous application and dense treatment. However, I don't normally use this. I prefer to use single spot, as a lot of the time the areas of edema are not homogeneous, and you need to use your high magnification contact lens together with the guidance from the OCT printout, the OCT map, to see where the thickened areas you need to treat. So I don't normally use the multi-spot mode for this. So here's what you can do. If you see an area of thickening in this area outside the macular infratemporal, you could use a customizable macular grid or square and treat this area. But again, single spot laser, which are continuous and contiguous, would be adequate for this. So it's always important to avoid lasering the fovea. So again, to repeat, there is no visible reaction during subliminal laser treatment. There's no need to change the power for different degrees of edema. As long as you've titrated the laser before starting treatment, that is adequate. And use OCT guided for diabetic macular edema. For cases of central serous chororetinopathy, ICG and fluorescein angiogram guided treatment is required, because you need to know exactly where the area of leak is to treat it adequately. A lot of people ask whether you should treat the fovea. I generally avoid treating the fovea, but you can go quite close here, as in this case here. And it's not recommended really. So you can go quite close, but I would avoid the fovea completely if there's an area of edema around it. How long should you wait after subliminal laser treatment? I will wait at least 3 months for diabetic macular edema and about 6 weeks for central serous chororetinopathy. Here are some examples where you can use. For diabetic macular edema, you don't need a fluorescein angiogram. The best patients that respond would be the non-center involved diabetic macular edema. And what it does is induces biological changes at the retinal pigment epithelium that close the microaneurysms, upregulate matrix metalloproteinases, and dry the edema. What about fovea involving diabetic macular edema? The best treatment options remains debatable. I always start with anti-VEGF therapy as first line to dry the thickened retina and improve the vision. And if there is residual edema about 2 or 3 months after the initial doses of anti-VEGF, you may consider topping up with some subliminal laser, especially if the patient is unable to come back frequently and is needle phobic. If the edema continues to be treated, always continue with anti-VEGF therapy. As for CSCR, you need to do ICGA and fluorescein angiogram to treat the hot spots. And I would treat the hot spots in the mid-phase fluorescein angiogram, following exactly the same protocols as for diabetic macular edema. So here's an example from my colleague in Tarragona, Spain, a patient with non-center involving diabetic macular edema. And you can see here, the patient had subfoveal, extrafoveal subliminal laser treatment, and you just have to wait patiently. At 3 months, there's visible reduction of the edema, and at 6 months, complete reduction of edema with just 1 subliminal laser therapy treatment. Here's an example of fovea involving diabetic macular edema, and the patient had 1 anti-VEGF therapy at day 0, and at 1 month after anti-VEGF therapy, there is reduction of edema, but still some persistent edema juxtafoveal. and one session of subliminal laser therapy was applied here. And at 4 months, you can see complete reduction of the edema with improvement of vision. No further anti-VEGF therapy or laser was required. Here's an example of acute central serous chororetinopathy, whereby subliminal laser therapy is applied to the hotspots on fluorescein, which corresponded with ICGA. And you have to be patient, and there's improvement after 45 days, and at 3 months, there's complete resolution of the neurosensory retinal detachment. What about chronic CSER? So here's a male patient with persisting subretinal fluid for 5 months, and he had fluorescein angiogram ICGA showing a persistent leakage superior to the fovea. And with 1 session of subliminal laser treatment, it was completely dry after 2 months with improvement of vision. Here's a patient with almost 1 year history of chronic CSER, and with treatment through the areas of hyperfluorescence on fluorescein and ICG angiography. There is reduction in the fluid, but vision did not improve very much because of the chronicity. But retreatment was done because of after 2 months, you can retreat. I will wait at least 2 months, and you have to repeat the angiography to see where the leakage. And after second treatment of subliminal laser treatment, it was completely dry. So that ends my presentation. I'd like to thank everyone for joining me today. And I hope this will help you in your journey towards using laser therapy for diabetic macular edema and central serous chororetinopathy.